Welcome to my YouTube channel. Today we are going to talk about the pathophysiology of preeclampsia. Kindly make sure you subscribe. Let's dig in. Pathophysiology behind preeclampsia. In preeclampsia, we normally have inadequate trophoblastic invasion. So the sincere trophoblasts normally invade the spiral artery. These are the spiral artery as mentioned. So you can see spiral artery. So they normally invade spiral artery, creating a low resistance. So if you know our normal physics, if we have a large lumen, then we are going to have low resistance. However, in preeclampsia, we have inadequate invasion of this trophoblastic invasion, as you can see here. So therefore, we will resort to high resistance uteroplacental circulation, therefore causing preeclampsia. So we continue. So this is just a repetition. Pathophysiology, it's a multifactorial initial etiology, as we mentioned before, which usually result in inadequate trophoblastic invasion. And the sincere trophoblastic, which normally invades the uterine spiral artery to establish a low resistance uteroplacental circulation, don't do so. So failure to do so then results to subsequent impairment of uteroplacental perfusion. So now, because you have inadequate uteroplacental perfusion, therefore you'll have placental ischemia, which then will result to oxidative stress and production of toxin, which now enter circulation. When this toxin enter circulation, you'll now have widespread inflammation, endothelial injury, and dysfunction leading to arterial permeability, and then you can have inappropriate activation of the coagulation. So the net effect of the processes that you have talked about will result to widespread vasoconstriction resulting to systemic hypertension and ischemic in various vascular beds. In addition to that, you're going to have extravasation of fluid from the intracellular space. This is because already the vascular membrane, or you have increased the membrane permeability. Also, you'll have intravascular coagulation with progressive consumption of coagulopathy. So just as a repetition, so we say the pathophysiology is caused by inadequate invasion of the cystotrophoblastic cells in the spiral artery, resulting to high resistance uteroplacental circulation. When you have reduced uteroplacental circulation, then you're going to have ischemia, and that ischemia is going to produce toxins. And now when you have these toxins are going to enter into the bloodstream, causing inflammation, increasing permeability, and also coagulopathy. So this is a summary of the pathophysiology, where you have weak or inadequate trophoblastic differentiation during the process of endothelial invasion. This now will result to abnormal development and remodeling of the spiral artery in the deep myometrial tissue. So later you'll have a high uteroplacental circulation and later have placental hypoperfusion and ischemia. So this now will result to toxins that will be producing that will now enter the bloodstream and now cause cascade of inflammation with placental release of cytokines, as I said before, disrupting the balance of angiogenic factors and inducing platelet aggregation. So in result, you are going to have systemic endothelial dysfunction and later have systemic hypertension. So the pathology, we're going to start with the placenta, which we said is lack of the decidualization of the myometrial segment of the spiral artery. So normally, the invasion of the spiral artery by the trophoblastic tissue results in the replacement of muscular and elastic layers of the spiral artery by fibrinoid and fibrous tissue, therefore resulting to large, tortuous, low resistance channels that extend through the myometrium, as previously mentioned. So when you don't have this, you're going to have narrow and high resistance channel. In preeclampsia, such changes are mostly limited to the decidual segment of the vessel. As such, the myometrial segments of the vessel have reduction in diameter, I said before, compared to that of a normal placenta. Glomerular capillary endotheliosis, as it said before, that you're going to have inflammation and production of cytokines because of the toxins that are released due to the placental ischemia. So this will result to glomerular capillary endotheliosis, which will have marked swelling of the glomerular capillary endothelium with marked deposits of fibrinoid material in and beneath the cells. In addition to that, we said that you're also going to be having ischemia in vascular beds. So you're going to have ischemia, hemorrhage, necrosis in multiple organs.